Thank you very much for joining us on this child psychiatry seminar. I work as a child and adolescent psychiatrist in the Department of Psychiatry, and I'm very interested in treatments for people who've been exposed to trauma. And I suppose what's happened over the last 20 years, I first trained in narrative exposure therapy in 2001, and I was the first UK professional to train in it. So it's been a wonderfully interesting, exciting journey, is that more and more in whatever area of clinical practice I've been observing, I'm starting to see individuals who've had very traumatic experiences which have not properly been treated or addressed. So what I'm going to be doing is talking a little bit about PTSD and then moving on to NET and examples of the adaptations. So trauma has a whole range of psychological sequelae, and we're learning more and more about what this range is. There are acute and longer term implications of it, a lot of associations with a range of different mental illnesses. For example, anxiety disorders, depression, substance misuse. And then on the extreme end of the spectrum of responses to exposure to trauma is post-traumatic stress disorder, which with the latest categorizations is becoming broader and broader as to whom you can diagnose with. But it's usually a reaction to a life-threatening disorder. And there is some debate about the cross-cultural medicalization of normal human emotions and experiences, but I'm not going to be exploring that today. So just to remind people of the DSM-5 diagnostic criteria of PTSD, you need to have had direct exposure to a stressor. You get intrusive memories or re-experiencing either through kind of flashbacks or repeated reliving in dreams and nightmares. There's altercations in cognitions and mood, feeling kind of emotionally numb, blunted. And then avoidance of stimuli that might arouse any recollection of the trauma. And it's a sort of an effortful avoidance. If you know that you might be exposed to anything that might remind you of it, this sort of everything in your body tells you to avoid it. And then you get these altercations in arousal with hypervigilance, exaggerated startle, and insomnia. Yesterday, actually, we published a big repeat systematic review of the prevalence of mental illness in refugee populations, and PTSD is around 22%. So in certain populations, it's high. And I came to this through refugees, but the point of this seminar is to talk about its relevance in other areas of our practice. I also just want to talk briefly about intergenerational effects that across disciplines, social sciences included, history, we're understanding these very, very complex intergenerational effects of PTSD. And that's why I think it's so important that we really prioritize the treatment of it so that we prevent the kind of exposure in the next generations. You get these parenting clusters of adversities across generations, disruptions to the parenting role, mental illness and aggression. So not too long ago, Humans in New York, which is one of my favorite Instagram feeds, showed this, and I just wanted to share it. I'm wondering whether Helen would mind reading this.
Sure. Yes, so my childhood was dominated by her stories, living in the ghetto for 2 years, surviving off potato peels, running like an animal from the Nazis. She was the only one who survived. I had no grandparents, no aunts or uncles. Her entire family was killed. We rose up from the ashes and my mother became a monster. She deprived us like she was deprived. My brother and I were always made to feel like a burden, like we were leeching from her. There were no special occasions, no birthdays, no cake. Everything was counted, everything was calculated. Whenever I asked her for something, I was made to feel responsible for World War II. She'd say, I didn't survive Hitler to get you a bag of potato chips. She never let me feel like we were in America. I felt like I was the only one wearing stripes. I've dreamed about Hitler since I was a child. He tells me I'm a mistake and that I should have been killed. I remember when I grew older and started visiting the houses of friends, I saw how their parents treated them, how they were given gifts, and how they were loved. I felt like I was crawling out of the sewer after the war and learning that this entire time, some people had been living normal lives.
Thank you, Helen. It's a very, very, sad story. And obviously extreme. The vast majority of people who've been exposed to trauma would not parent in this manner. But this is just why it's so important. If this, you know, I just constantly think if this woman had an opportunity to access interventions that are far more available today, maybe this child's experience of being parented would have been incredibly different. So there's a study that came out last year looking at refugees over 20 years, and it showed that if their parent had PTSD, the child had a much greater likelihood of a whole range of psychiatric diagnoses. And that was regardless of whether that child was born in Denmark or elsewhere. And Amanda Sim did quite an interesting study of parents in Lebanon in a refugee camp, and kind of came up with this quite interesting way to think about how different components of vulnerability and hardship can impact on the ability to parent, with kind of economic hardship leading to reduced parental supervision, fewer opportunities for parents and children to interact, the psychological difficulties of parents possibly leading to harsher parenting, and then the hypervigilance that comes with exposure to trauma and the fear of danger leading to increased parental control and kind of the toxicity of that. And so I've kind of made this little diagram thinking about a parent PTSD and the child, and how all these components, emotional numbing, hypervigilance, avoidance, mood disturbance, you know, how that would play in as you're parenting a child that might be distressed, and what we could do to move this into a possibility for that child to explore. So this is where avoidance comes into play. I think this is one of the key things we need to address, because avoidance, when it comes to treating exposure to traumatic events, I think plays on many levels. So for the individual, like I've described with the core symptoms of PTSD, one of the core symptoms is avoidance. So it's incredibly difficult to bring someone into a therapeutic space when everything in their mind and in their body is telling you to avoid going, because they know that in treatment they'll be exposed to memories of the thing that they're trying to avoid. And with so much comorbidity psychologically and potentially physically, in a way you can get distracted by treating the depression, treating the anxiety, and these primary traumatic events often just don't get treated because the individual doesn't want them to get treated. And then for a parent, well, it might feel like it's an important part of your role as a parent to protect your child from any memory of that traumatic event. So coming into a therapeutic space where we're going to explore that might be, as a parent, you're like, well, that's not what my child wants. It's going to upset my child. I might not think that's the best thing to do. But also, if you as a parent might have also suffered from the same trauma, then actually, if they're also avoiding that, how difficult it would be then to help their child address it. I also think therapeutically, there have been a lot of kind of narratives around you've got to be completely in a stable place before trauma is treated in an individual. And this is where I find narrative exposure therapy so interesting and important, because they've just thrown that whole stability presumption out the window and just said you just can treat even in the most unstable circumstances. You need a lot of training and supervision. I think as a therapist, if I had to choose between kind of one patient, which might be relatively simple phobia, versus someone who's had horrific exposure to terrible events, it's quite difficult to constantly be working therapeutically with these types of events. And so in a way, there might be a therapeutic avoidance, which is why it's so important to have supervision as well. I think there's very few good research done into these events, and then the whole broader societal responsibilities. You know, I'm embarrassed to say, like, as an individual, if I know someone who's gone through terrible, terrible events, sometimes I'm not sure how to approach them, and occasionally I might not approach them when I would have otherwise. So I think as a society, and as individuals, we need to be aware of how much we might avoid people who might have been exposed to terrible events. I'm now going to go into the narrative exposure bit. So narrative exposure therapy is all around thinking about trauma narratives. And the presumption is that when you've been exposed to a traumatic event, that memory is encoded in a fragmented way, not in chronological order. And hence the individual finds it difficult to put the experience they've had into words. And this is just a diagram to talk about the taxonomy of memory. I'm not going to go into it in detail, but just that in a way we're dealing with two areas of brain, the hippocampus and the amygdala, and I'll tell you a bit why. So in our autobiographical memory, so the memory we have of what happens to us in our life, there are knowledge about lifetime periods, like my childhood, a knowledge about specific events, like the first day I went to school, and then knowledge about general events, like the pandemic. And then there are kind of event-specific emotional memories that raise up a whole sensory network. Like that day I got bullied and it was horrific, and you feel kind of emotional, emotions rise in you. So in the narrative exposure world, and in many other worlds as well, but we really focus on what we call the cold memory and the hot memory, that those memories that are just encoded in a way that doesn't elicit a response from your emotions is a cold memory, and then the hot memory is the one where you get the sensory network gets awakened. And thinking about stress, basically the hippocampus, the one in blue, is where most of the nice cold memory gets encoded. But when stress levels rise, in a very simplistic way, we've got to think that that memory then gets encoded much more in the amygdala, a very primary part of the brain to do with fear, fight, and flight. And that contributes to the sensory component of the memory as well being encoded. So we have these hot memories that are activated by cues, so you get sensory as well as physiological perceptions with it, fragmentary, a feeling of it happening now, sort of coming into the flashbacks of NET. And then you've got the cold memory, which is deliberately retrievable, knowledge about specific events, and it's a chronological report. And so everything about NET is about bringing these hot memories into cold. So what is narrative exposure therapy? Well, it's a brief intervention for PTSD symptoms. It was developed in refugee camp areas in Uganda. It's simple and effective. It's been shown to be able to be delivered by lay people following short training, which is really interesting, thinking about the type of training that often you might think you need to go through in order to treat PTSD. This lay people have been trained to deliver it, and next week in the departmental seminar, Katie Robjohn will be sharing a bit about her experience of doing that in the Democratic Republic of Congo. It can be very culturally dexterous because it's really around a narrative, and it also bears witness to human rights violations if that's relevant. So thinking about NET, the goals are to reduce PTSD symptoms by reliving these events in the here and now, strengthening the autobiographical memory, and interweaving these hot, very emotionally driven memories with cold memory in order to bring a fragmented memory into chronological order, and then emotional processing at the same time. While you do that as a therapist, you construct a documentation of the narrative. So we chronologically sort those memory fragments. We bring in as much contextual information as possible and really focus in detail on the traumatic events. So the overall structure of NET will be that you do assessment. And I think the psychoeducation is incredibly important, and that brings me back to thinking about parental cognitions and also about avoidance. So really to normalize the symptoms, to explain what you're doing, but really to say that it's normal to not want to come to therapy. In session 2, you do the Lifeline, and then 3 to 10 is the core bits of NET, which is a construction of the narrative. So I'll talk you through the Lifeline. So this is a really interesting therapeutic tool that we find really important in narrative exposure therapy. So there's a bit of string, you use flowers and stones, you can use whatever you can find on the ground around you, really. So the rope is used as a symbol to life, so you roll it out, you say this represents your life, and then there's the bit that hasn't rolled out yet, that's the future. Flowers are symbols for good events, stones for bad events. And we use this to map therapy. So we ask the young person to go through their life from the beginning, from when they can remember, and to mark the events that they would like to mark with either a stone or a flower, and to name that event. Now, this is just a roadmap. We don't hold a young person to it because we would expect some of the most difficult traumatic events not to be shared at that first meeting while trust builds up and develops. And so during the Lifeline, the therapist will chronologically helps order the stones and flowers, give everything a name, and you get a bird's eye view. As I said, don't forget the missing stones. And this Lifeline is the therapist's best friend, because you can sort of map out how many times you might need to see someone, whether they're 4 big stones, and so I might need to see them 5 or 6 times, versus 10 stones where I might want to see them 10 times. And then the actual process of NET is kind of going through the stones in a lot of detail, reading them, and then the next session, reading the narrative that you as a therapist will write in between sessions, fill in more details, and really expose people to that memory in a chronological, cold manner. And then the final session is just an ending and a handing over the narration. So thinking about the narration, you go through it in chronological order, constantly bringing in the context. Most of the time in sessions is taken narrating the stones. The therapist creates safety, constantly challenging avoidance, saying things like, I know this is the worst bit. It won't help to stop here. You're not on your own. I'm here with you this time. So, for example, someone would go through their life, starting at birth, telling us a bit about what had happened. And then when you get to the first traumatic event, we slow down and we kind of watch this kind of hot memory as the fear networks gets triggered. People's kind of heart rates might get faster, they might breathe faster, and the memory is fragmented. And so then we go really slowly, and this is quite hard work for the therapist. We kind of establish when it happened, where it happened, who was there, what. And I say when I'm training therapists, you've got to imagine you're a film director and you're going to be shooting this film. You need to know every single little detail of what has happened. So we're fully exposing the person to everything, and we're putting it in chronological order, making sense of it, understanding it, writing it down, and constantly working with the person until that narration is finished and actually the arousal goes from hot to cold. And the aim is to habituate that person to that memory over time. And NET has a very, very impressive growing evidence base. These are just the studies that have been done in children. It is under the latest NICE guidelines for PTSD treatment in adults. It's been categorized under cognitive therapy, so it's been categorized with CBT, but it is very different. So many of us weren't too happy about that categorization, but it has a very impressive evidence base for treating multiple traumatic events, or chronic PTSD, or complex PTSD as it's called. So in summary, I really think we have to think about what is preventing people accessing care. One of the reasons might be that we don't have those services to offer and the treatments to offer, but actually there are treatments available, but there are a whole host of other reasons why a young person might not be able to access that. And we have to think about those barriers, especially avoidance, in the way we think about caring for these young people. Like, sometimes, someone misses an appointment, they miss their second appointment, and, some services will just discharge that case. Well, obviously with PTSD, we cannot be adopting those kind of very, very black and white models of care delivery when there are such complex emotions at play. So we've got to think about avoidance, and then just to think, NET, narrative exposure therapy, it's well received. It's a very short training. It's a 2-day training for mental health professionals. There seems to be little dropout. It's brief, it's focused, and does seem to be very effective in reducing PTSD symptoms. It's scalable, and even lay people without mental health backgrounds have been able to apply it effectively. And I really think, in every service I go to, I see people who potentially have had traumatic events that are impacting on their functioning that have not been addressed, and really it's sort of a mission for me to do what we can to address that. So just do think about this woman and her tragic story, and a lot of people to thank, including my co-presenters.